friends, this is Shruti Joshi and today I am going to talk about drug acting on cardiovascular and pulmonary system. So let's have a look on that. Before we learn cardiovascular and pulmonary system medication, we need to know about some basic idea of central nervous system and peripheral nervous system. The central nervous system is divided into two parts, brain and spinal cord. And the peripheral nervous system, it will divide into motor, efferent, ME, just remember me, and it will carry the impulses away from the CNS. So CNS to muscle it will carry, and the sensory efferent SA, it will carry the impulses towards the spinal cord, means sensory organ to CNS. Again your motor is divided into somatic and autonomic nervous system. So somatic nervous system has a voluntary movement control and autonomic nervous system has involuntary movement control. Again autonomic nervous system, it is divided into sympathetic and parasympathetic nervous system. So sympathetic nervous system, that will mobilize your body during activity. For example, here the bus is coming towards you. So that time, will you stand there or will you move? You will move from there. Or sometime you will change your path. So that is fight or flight reaction. And parasympathetic nervous system, that will calm your body and means rest and digest. Now we are going to see somatic and autonomic nervous system pathway difference. So this is your somatic nervous system and this is your autonomic nervous system. For somatic division, the cell bodies that lies in like the cell bodies of motor neurons that resides within CNS, means spinal cord and brain. Their axons sheath are like these are the sheath in spinal nerves, and it extend the way of to the skeletal muscle. So this is like your, here we can draw myelinated receptors. This is the autonomic nervous system division. So it has chain of two motor neuron, preganglionic and postganglionic. So these are the preganglionic neurons. So the preganglionic neurons may be myelinated or unmyelinated. They are type B and these are type C and unmyelinated. The preganglionic that lies within the CNS and postganglionic outside the CNS. Now we are going to see autonomic nervous system integrations. So for example, let's take for baroreceptor reflex. Baroreceptor reflex, that will control your blood pressure. For example, your blood pressure is decreased, so that is sensed by baroreceptor reflex. So what baroreceptor reflex will do? It will directly report to your brain, and that's why there is increased sympathetic discharge. So if sympathetic discharge is increase heart rate, increase peripheral vascular resistance, increase cardiac output, and it will decrease your parasympathetic activation. So your parasympathetic activation is decreased and your sympathetic activation is increased. That's why your BP is under control. Let's take reverse for it. If your BP is, blood pressure is increased, so baroreceptor will sense that, it will report to your brain and increase parasympathetic activity, means calm and cooling activity, and that it will control to decrease your sympathetic outflow. So that will control your blood pressure again. Now we are going to see autonomic. This is your autonomic neurotransmitters. So autonomic neurotransmitter, they are acetylcholine or norepinephrine. So acetylcholine, their receptor is cholinergic receptors, and your norepinephrine receptors are adrenergic. So for cholinergic, it is again divided into nicotinic and muscarinic receptors. So where it is located? Your nicotinic receptor, that is located between pre and post ganglion of central nervous system and peripheral nervous system of skeletal muscle, and your muscarinic receptors are located on postganglionic neuron. For norepinephrine neurotransmitters, they are adrenergic they are divided into alpha and beta. So again their alpha is divided into alpha 1 and alpha 2, and beta is divided into beta 1 and beta 2. Let's take for alpha 1 receptors. So alpha 1 receptor, they are located in vascular smooth muscle responsible for vasoconstriction. Alpha 2 are in CNS. Let's take for beta 1 and beta 2 receptor. They are located in your heart and kidney. So if it is located in heart, so it will increase your heart rate, increase contractility. And for your beta 2 receptor, it is located in your lung. So that will cause bronchodilation, that will decrease GI motility also, and skeletal muscle metabolism will increase. Now we are going to see autonomic nervous system stimulation and response of effector organ. So effector organs are heart, lung, kidney or arterial. Let's see. For sympathetic effector organ heart, so it is sympathetic will be increase your contractility, beta 1 and beta 2 receptors, increase heart rate. For lung, it will cause bronchodilation, beta 2 located in lung. Kidney, it will increase renin angiotensin secretion, alpha 1 and beta 1. For arterial, it will cause vasoconstriction of skin and viscera, alpha 1 and alpha 2 receptors, vasodilatation of skeletal muscles and liver. For parasympathetic, the effector organ is heart, so it will decrease your heart rate, muscarinic receptors, slight decrease in contractility, muscarinic receptors. And for lung, if parasympathetic is activated, so at that time bronchoconstriction will occur. And for kidney and arterial, there is no parasympathetic innervation is there. So just we need to know about location of alpha 1 and alpha 2, beta 1 and beta 2 receptors, and what happen if sympathetic activation is there, what happen if parasympathetic activation is there, especially for heart and lung. Let's have a look for nitrate. So what nitrate will do? So first drug name is nitrate, nitrostate, so that is nitroglycerin. This is a brand name. So isodril, isosorbate dinitrate. It is used for angina pectoris. Main mechanism of action is smooth muscle relaxation, that will decrease preload through peripheral vasodilatation and improves coronary blood flow. So there will be reduce in myocardial oxygen demand and reduce anginal pain. So what is your preload? Preload means there will be like at the end of the diastole, it will stretch your ventricle. So this stretching is decreased because when patient is having anginal pain or myocardial infarction, so that time your arteries will narrow. So if there is vascular smooth muscle relaxation with the help of nitroglycerin, so nitroglycerin that will relax your smooth muscle and vasodilatation is there, so there will be increased flow of blood and there won't be any stretching problem for your ventricle, so that is decrease and that will decrease your pain. So these are the mechanism of action for nitrate. The main side effect is hypertension. As a physiotherapist, we have to be aware about the side effects also. So because patient have vasodilatation that cause hypertension, patient may have vertigo, dizziness, flushing headache, and reflex tachycardia is again a major cause for side effect. So as a physical therapist, what should we do for this patient? If patient is coming to you for physiotherapy, so that time he might have hypertension, so educate patient about this hypertension and tell their family members also. If acute anginal attack is there, they should carry their sublingual drug with them, and they have to administer as indicated. If condition is worsened, we need to immediately notify their physician. And if hypertension is there, so we should take care to change their position. So we should not take suddenly upright position for them. Okay. Now we are going to see beta blockers or beta adrenergic blocking agents. Earlier we have seen that beta adrenergic blockers have beta 1 and beta 2. Beta 1 will work on heart, beta 2 on lung. The brand name is Inral. It's known as propranolol. Second is tenormin, that is atenolol. Third is low-pressor, so that is known as metoprolol. Just remember LOL at the end, so that is known as beta blocker. The condition like hypertension, arrhythmia, chest pain and heart failure, we can use beta blockers. What is the mechanism of action? It will block adrenergic receptors. So adrenergic receptors are responsible for increased heart rate, contractility, and if we are blocking it, it won't increase your heart rate and contractility more. So that will decrease myocardial oxygen demand and increase myocardial oxygen supply, and that by reducing heart rate and contractility. Let's see individually for hypertension, chest pain, heart failure and arrhythmia. First of all, we are going to see for heart failure. So for heart failure, patient have almost all the patient have systolic heart failure. So systolic dysfunction is there. If systolic dysfunction is there, so there is contraction problem. Contraction problem means it is contracting too much, it's not relaxing. So by reducing your contractility, it will improve your O2 demand. So more oxygen supply will be there, it will allow your heart to relax, and that's why there will be control of your heart failure. Now we are going to see hypertension. Before that, let's erase this. Now we are going to see hypertension. So for hypertension, what happens with beta blocking agent? It will decrease your blood pressure, decrease your cardiac output, and with the help of decreased blood pressure and cardiac output, there will be increased myocardial oxygen supply, and your blood pressure will under control. For anginal pain or chest pain, there is increased myocardial oxygen supply and decreased demand, and mostly the patient is having infarction, so that time their L3 elevation MI is there. So with decreasing your contractility and decreasing your heart rate, it will supply more oxygen, so that cause decrease chest pain. Most of the patient is having reflex tachycardia, bradycardia and dizziness. So other side effects are fatigue, weakness, blurred vision and arrhythmia. So as a physiotherapist, what are the duty for us? Patient may have orthostatic hypertension, so heart rate and blood pressure response for exercise is decreased. We have already seen it will reduce your heart rate and contractility. So use rate of perceived exertion to monitor the exercise intensity, because there might be blunted heart rate response is there. So if you are measuring the intensity with the heart rate, so that is not reliable. It may mask the tachycardia in diabetic patients, because in diabetic patient they have they might feel hypertension. So hypertension is caused for them, and if patient is feeling hypertension, so immediately we need to tell them just sit for 5-10 minutes and give them candy or just fruit juice. So it will reduce their hypotension. For asthmatic patient, take care if patient is having asthma, so it will block, like beta 1 is for heart, beta 2 is for our lung. So lung, it will cause constriction. So don't increase exercise intensity suddenly. These are the warning signs for hypoglycemia, like masking the diabetes, masking the tachycardia. So sit down, just give fruit juice or candy, and if it is more worsened, so just notify their physician and tell them to contact their physician immediately. Now we are going to learn Renin angiotensin system. So this is necessary because we are going to see ACE inhibitors. For example, when your blood pressure is lower or drop in your blood pressure, so kidney will release renin. Where it will release renin? It will release renin in the blood circulation. So that will this renin will react with protein that is known as angiotensinogen, that is produced in liver, and that form angiotensin I. So angiotensin I that will use is angiotensin converting enzyme from the respiratory system and convert into angiotensin II, and that angiotensin II will circulate in blood and affect the cardiovascular system. Let's see angiotensin II cardiovascular system effects. So angiotensin II stimulate adrenal cortex. So when there is a stimulation of adrenal cortex, it will release aldosterone. So if aldosterone is released, there is constriction of blood vessel and there increase water resorption, plus increase in sodium in kidney that cause increased blood volume and increased sodium, increased blood pressure, and this all lead to increase or rise in blood pressure. Now we are going to learn ACE inhibitors or angiotensin converting enzyme inhibitor agents. So if we are directly inhibiting the ACE angiotensin converting enzyme, so that won't convert angiotensin I to angiotensin II. So there won't be any cardiovascular side effect of angiotensin II. Let's see the drug name. Just remember pril for and. So if you are remembering the ACE inhibitor, pril is the suffix used for it. So capotane, it is known as captopril, vasotec enalapril, prenivil means lisinopril, altease means ramipril. Especially it is used for congestive cardiac failure patient and hypertension patient. Mechanism of action, like it is suppressing the angiotensin converting enzyme that converts angiotensin I to angiotensin II and decreased afterload and blood pressure. Main side effect is dry cough, hypotension and hyperkalemia. Other are dizziness and hypothermia. As a physiotherapist, what we should consider for this kind of the patients? So patient may have hypotension, avoid sudden positional changes and avoid sudden increase in exercise intensity or activity. If patient is having hyperkalemia, just notify immediately to their physician. Now we are going to learn angiotensin II receptor antagonist agent. So what is angiotensin II receptor antagonist? When angiotensin II, it has a angiotensin I and angiotensin II receptor. So angiotensin II that will increase aldosterone, increase sympathetic activity, increase heart rate. If we block this angiotensin II receptor, so there won't be any other abnormalities in your heart. So that's why it is known as angiotensin II receptor antagonist agent. So drug name, just remember sartan, sartan, sartan. So losartan, valsartan, condensartan, these all are angiotensin II receptor antagonist agent. It will reduce your blood pressure by blocking angiotensin II receptor that limits vasoconstriction. It is used in hypertension, congestive cardiac failure patient, Main side effect is pain, dizziness and back pain. So as a physiotherapist, we need to educate the patient about dizziness. So their family members also, they need to learn when patient may have attack of dizziness. Now we are going to see action potential in cardiac muscles. So action potential in cardiac muscle at the phase 0, it is same as the skeletal muscle. So at rest there is a negative inside and positive outside, but when depolarization start, at that time sodium influx means sodium goes inside, so there will be positive charge inside and negative charge outside. But when there is a repolarization, that time here we can notice that the potassium goes out, so again outside it is positive and negative inside. Let's see cardiac muscle action potential. So this is phase 4, 0, 1, 2, 3 and 4. So here in phase 0, rapid depolarization occurs. Sudden sodium comes inside and open sodium gated channel. So in phase 1, early brief period of repolarization, because potassium channel leave these cells, so that become repolarization, negative charge inside again. In phase 2, action potential go for some plateau, because for a long time calcium channel get open, so that is unopposed calcium channel and it will remain plateau, so that allows your cardiac muscle to go for systole and diastole. In phase 3, again repolarization is completed, calcium channel is closed and potassium influx is occurred. So in phase 4, slow spontaneous depolarization occur, like sodium leaky channel is open and potassium goes out, is decreased. So potassium efflux is decreased, so more positive cell inside, that lead to the spontaneous depolarization. These all are important because we are going to learn about cardiac medications. Now we are going to learn anti-arrhythmic agents. So anti-arrhythmic agents are having class 1 agents. So for class they have, class 1 is sodium channel blocker. So earlier we have seen that sodium channel blocker is needed for phase 4 and phase 0. So that time if we increase their depolarization phase, so there will be long refractory period we get, and that's why we can prolong their refractory period, and there will be slowing in the heart rate and conduction, so our cardiac excitation is lower, so that will control specifically supraventricular tachycardia like atrial fibrillation. Drug used for that is quinidine and xylocaine. So like xylocaine is also known as lidocaine, mainly used for cardiac arrhythmia. Mechanism of action is cardiac conduction and excitation control. Especially this drug will cause hypotension, ventricular tachycardia. This is fatal, so if it is notified, immediately report to their physician, and hypotension is there, so care for positional changes. Now we are going to learn class 2 anti-arrhythmic agent, that is beta blockers. So beta 1 and beta 2 receptor, beta 1 located in heart, beta 2 located in lung. So if we are blocking beta 2 receptor at the heart, so that will decrease firing at SA node, especially here it will decrease firing, and at the AV node there will be decrease in conduction, so decrease sympathetic activation. Let's see the drug name. It's tenormin, especially the brand name is tenormin, but the generic name is atenolol. So this will help you to control cardiac arrhythmia, atrial tachycardia and atrial fibrillation. Mechanism of action, it inhibits sympathetic activation by blocking beta adrenergic receptor, decrease cardiac automaticity and prolong effective refractory period, thus slowing in heart rate, so that will control your arrhythmia. Main side effect is slower the cardiac conduction and increase reflective arrhythmia. As a physical therapist, what we should consider, especially patient may have orthostatic hypotension, So we should know about orthostatic hypotension, and we need to educate the patient about the sudden positional changes, and we should not change their position suddenly upright into supine. Like that way we cannot change the position. Heart rate and blood pressure response to exercise is decreased, so that's why we use rate of perceived exertion to monitor exercise intensity, and we can not improve their exercise intensity immediately. We have to go step by step. Now we are going to learn about class 3 antiarrhythmic agent, that is sodium and potassium channel inhibitors. So drug name is cordarone, and the generic name is amiodarone. Especially this is used for cardiac arrhythmia. It prolongs repolarization by inhibiting sodium and potassium channel, and that's why your heart rate is decreased heart rate. Main side effect of amiodarone has a pulmonary toxicity and liver damage. As a physiotherapist, we should take care about hypotension and sudden postural changes. Now we are going to see anti-arrhythmic agent class 4, that is calcium channel blockers. So that are verapamil and cardiazem. So cardiazem is known as diltiazem. Mainly it is used for cardiac arrhythmia. Main mechanism of action, it depress the depolarization and slow the conduction through AV node. Here in this diagram we can see this is SA node, this is AV node. So when there is a decreased sympathetic activity, there will be decreased firing at SA node, and here we can notice that this is AV node, so conduction velocity is decreased at AV node, that cause decrease in your heart rate. Main side effect of verapamil, it will slow down your heart rate by inhibit calcium entry into cardiac muscles, so there will be excessive bradycardia. There is reduction in calcium entry into vascular smooth muscle, which may cause peripheral vasodilatation, leads to dizziness, headaches, and hypotension in some patients. So as a physical therapist, we need to see for hypotension and take care for sudden postural changes. In this patient, they may have blunted heart rate response and hypotension, so we have to use a rate of perceived exertion for this patient, and we cannot increase their workload suddenly. We have to increase workload gradually for this kind of the patients. Now we are going to learn calcium channel blocker separately. So calcium channel blocker, just remember dipine, Norvasc, amlodipine, procardia, nifedipine, Calan, verapamil, cardiazem means diltiazem. So mainly what this drug is used for, what cause, for like arrhythmia, congestive cardiac failure, hypertension, angina pectoris. So mechanism of action, decrease calcium entry in vascular smooth muscle. So if your calcium is decreased, so your excitability of SA node is decreased, firing rate is decreased, and here at AV node discharge rate is also decreased. So AV node conduction velocity is affected, and that's why patient may have vasodilatation and reduce oxygen demand, and that reduce their heart rate. Patient have side effect like hypotension, dizziness, headache, and peripheral edema. Hypotension is main cause. So as a physiotherapist, we should take care for postural or orthostatic hypotension is common. Monitor patient closely for the hypotension and take rate of perceived exertion, because patient have blunted heart rate response and blood pressure response. That's why we are using RPE. Let's have a look for anticoagulant drugs. Anticoagulant drugs are heparin, comedian means warfarin, and Lovinex means enoxaparin. Especially this anticoagulant used for coronary artery bypass graft surgery, percutaneous stance luminous coronary angiography, and venous thromboembolization prevention. Main mechanism of action of anticoagulant, it inhibit platelet aggregation and thrombus formation. So it won't allow formation of thrombus, and because in post CABG and PTCA patient it is very common. So this won't allow inhibition of platelet aggregation and thrombus formation. Main side effect is hemorrhage, increased risk of bleeding, and it decrease clotting. Especially patient may have GI disturbance like nausea, vomiting, stomach cramp, and diarrhea. So as a physical therapist, we need to take care of patient during exercise, because if they are doing excessive exercise, or if they hurt themselves, so that will cause for physiotherapist. So avoid injury, and that may lead to bruise, bleeding, hemorrhage. Educate the patient about the correct positioning and everything, so they can avoid the injury. If we are giving chest physical therapy, so that time percussion and deep tissue massage we should use with caution, because internal bleeding may occur for this kind of the patients. Now we are going to learn antithrombolytic agents. So drug name Activase means streptokinase, and Ninlytic urokinase. These drugs indications are acute myocardial infarction, pulmonary embolism, ischemic stroke, venous and arterial thrombosis, because thrombosis is very common in these conditions. What is the mechanism of action for this? Antithrombolytic agents that will facilitate clot dissolution, and especially it will occur through conversion of plasminogen into plasmin. So that allows clot breakdown and reopen the vessels and maintain the blood flow. The main side effect is hemorrhage and cardiac arrhythmia. So as a physiotherapist, we need to educate the patient to avoid the injury that may lead to hemorrhage for that patient. Now we are going to learn anti-hyperlipidemic agents. So anti-hyperlipidemic agents are Lipitor, atorvastatin, Zocor, simvastatin. These are two largest selling drugs. Lescol means fluvastatin, Memacor means lovastatin, and Pravachol means pravastatins. So just remember statins for this. Mostly it is used for atherosclerosis, coronary artery diseases, peripheral vascular disease, and diabetes. Main mechanism of action, they will work on inhibition of HMG coenzyme A inhibition. So if HMG coenzyme A inhibition is there, so that will break down the low density lipoprotein. If our low density lipoprotein is less, so atherosclerosis and coronary artery disease can be prevented. And it also decrease triglyceride and increase high density lipoprotein level. Main side effect is GI disturbances, nausea, vomiting, etc. So as a physical therapist, we should take care for this patient, like if they are doing aerobic exercise, so that increase HDL level and it maximize the drug effect for therapy. Now we are going to see diuretics. So diuretics are thiazide, loops, and potassium sparing agents. This thiazide diuretics known as diluryl chlorothiazide, loop diuretic known as Lasix, furosemide. Potassium sparing agents are spironolactone known as alloxone and triametrin. So direnium. Mainly it is used for hypertension, pulmonary edema, glaucoma, and heart failure. The patient have more edema in their legs, so for that patient we can use diuretics. Main mechanism of action of diuretics is, for example, thiazide inhibit the sodium resorption. Here, if thiazide is inhibiting sodium resorption, more excretion will be there from your body. So more water is excreted from your body, there will be less edema in your body. That's why for reduction of edema in heart failure, even patient may have pulmonary edema, so that will remove with the help of diuretics. In hypertension, it is also used and it used with combination of antihypertensive drug. Sodium is retained within the nephron, it is excreted and reduce plasma volume. That's why your blood pressure is less. So mostly these patients have hypokalemia because of loop diuretics. So if patient is having hypokalemia, there will be less potassium. So for that patient we need to take care. They may feel arrhythmia. Patient may have dehydration and orthostatic hypotension. Mainly this orthostatic hypotension and hypokalemia are main side effect of diuretics. So other side effects are electrolyte imbalance, increase low density lipoprotein and arrhythmia. As a physical therapist, we need to take care for hypotension. If we are changing certain position, patient may feel hypotension, so we should not change their position suddenly. If patient is feeling dizziness or fall, so we need to take care for electrolyte balance. Patient may have muscle cramp and muscle weakness, so we need to take care for that also. If patient is having hypokalemia, mainly electrolyte imbalance is there, so if it is potent problem, so immediately we need to notify their physician. Now we are going to talk positive ionotropic agents. So positive ionotropic means which increase your contractility of your heart. So the drug name are lanoxin, it is known as digoxin, dopamine and dobutamine. Mainly this will use for heart failure and atrial fibrillation. Main mechanism of action is increase force velocity of myocardial contraction. If your heart is contracting less, so that time it will help you to increase contraction. It will give you few contraction but better one. So dopamine act on beta 1 receptor, increase myocardial contractility, and main side effect is GI disturbances, hypotension and cardiac arrhythmia. If patient may have arrhythmia, so note their heart rate if less than 60 or 100, more than 100, so contact their physician immediately. It may be fatal for this patient. Educate their family member to monitor their pulse and heart rate during exercise also. Avoid exercise like whirlpool which cause vasodilatation, because patient already has hypotension, and if more vasodilatation is there, patient may feel more hypotensive, so that may that's why we need to take care for this kind of the patient if they are going for whirlpool bath. Now we are going to see digitalis toxicity. Let's see CNS sign and symptoms for digitalis toxicity. If patient has taken digitalis, so that time he may feel confusion, headache, delirium, psychosis, even weakness and hallucination. So if these kind of the symptoms are there, immediately we have to notify to their physician. If patient is having cardiac effect, so they may feel premature ventricular contraction, bigeminy or ventricular tachycardia, sinus bradycardia and ventricular arrhythmia. Again notify to their physician. If the patient is having GI disturbances, nausea, vomiting, that time they have to contact their physician and take medicine for that. Patient may feel like vision abnormality, photophobia, color perception problem, scotoma or hole problem. So these are all about digitalis toxicity. So if patient is coming to you, and as a physical therapist we need to know about these signs and symptoms. This may appear during exercise, so as a therapist, that is our duty to notify their physician. Now we are going to see pulmonary medications. Let's have a look for that. Before learning this medication, we have to see some receptors. So some are histaminic receptors. They are H1, H2, H3 and H4. So H1 receptor, they are located on vascular, respiratory and other tissues. So respiratory, it will located in your lungs. H2 receptor, they are located in gastric and gastric acid secretion. They will maintain in gastric acid regulation and secretion. H3, that is helpful for local regulation of histamine release from CNS. And H4, that will identify in your blood cells or cells derived from the blood cells. So for us right now, only H1 receptor is important because it is located on vascular and respiratory or other tissues. Let's see. Now we are going to learn antihistaminic agents. So antihistaminic agents are Zyrtec. Zyrtec means cetirizine HCl. So most of the patient having allergy, doctor will prescribe cetirizine for that patient. So brand name is Zyrtec. And if the patient is having cough and that is very severe or moderate cough, so they will provide diphenhydramide and the name is Benadryl. And third one is Elagra, so that is known as fexofenadine. Claritin means Loratadine Mostly these all drugs are used for allergy or respiratory allergy, rhinitis, common cold, motion sickness, conjunctivitis and Parkinson's disease. Main mechanism of action is block histaminic receptors and decrease nasal congestion or mucosal irritation. Here already we have learned that in your lung we have H1 receptor. So this receptor, if it is blocked, so that will relieve your nasal congestion and respiratory allergy. Main side effect is arrhythmia, GI distress, headache, drowsiness, nausea, fatigue and thickening of bronchial secretion. We have, as a physical therapist, we have to take care for orthostatic hypotension, because this is again a side effect for this kind of the drug. Mostly patient is taking Benadryl or cetirizine, they may feel drowsy or hypotensive. So for that patient we need to take care more. If they are coming to you, you are doing exercise for them, so we need to guard their patient during exercise, and we have to monitor them very closely, because if they may faint, so we need to immediately notify to their physician and we need to call 911. Now we are going to learn anti-inflammatory agents, that are corticosteroid, leukotriene inhibitor and mast cell stabilizer. This leukotriene are like their receptor is cysteine receptors, and that is located in mast cell, eosinophil, etc. So that may stimulate a pro-inflammatory effect, so that in asthmatic patients it will cause inflammations. And mainly this kind of the drug, this is used as a leukotriene inhibitors, and mast cell that will release histamine. So we have to use mast cell stabilizers to release to stop the inflammation and stabilize that cells. The drugs used for that are corticosteroids like QVAR, so that are beclomethasone and dipropionate. Second is pulmicort, so that is budesonide, and arrowbid means funisolide. The leukotriene inhibitors are Zyflo, Zileuton, Singul-Air means Montelukast, Ecolate is Zerfilucast. These are used for bronchoconstrictive diseases. And the mast cell stabilizers are nasal chrome, so cromylene sodium. Mainly this is used for asthma and bronchospasm. The leukotriene it inhaled leukotriene modifier for inhibition of leukotriene receptors, and mast cell stabilizers and corticosteroid we are using. Montelukast will block the receptors. Main side effect of corticosteroids are local and general. So in general means they have systemic side effects. So systemic side effects are tissue breakdown and skin breakdown, osteoporosis, glaucoma. Our bone mineral density is also decreased. There will be growth delay, and the local effect like nasal congestion, irritation, dryness, sneezing and bloody mucus is there. If patient is taking leukotriene inhibitor, it will damage their liver. And mast cell stabilizer that cause bronchospasm, nasal irritation, GI disturbances and cough. So as a physiotherapist, that is our duty to educate how to use the inhaler and avoid mucosal irritation. These drugs are not used for asthmatic attack. Acute asthmatic attack is dangerous, so if we are using this kind of the drugs, so that won't relieve their inflammation and patient may die. If patient reports signs and symptoms like jaundice, flu-like symptoms, fatigue, so immediately notify to their physician. Patient is taking corticosteroid, so that cause skin breakdown. So we don't need to overstress their bone or muscle, because muscle may become weak, and due to glucocorticoid or corticosteroids, if we are taking long time, so their ligament laxity will be there. Let's see bronchodilators. The bronchodilators are anticholinergic, sympathomimetic or xanthine derivatives. First of all, anticholinergic drugs. So anticholinergic drugs are atrovent or ipratropium. Spiriva means triotropium. Sympathomimetics are phentoline means albuterol or servant means salmeterol. That is short-acting beta-2 agonist drug. And xanthine derivatives are theodule means theophylline or aminotheophylline. Mainly this is used for bronchospasm, wheeze or shortness of breath in asthma and chronic obstructive pulmonary diseases. Main mechanism of action is bronchodilator that will relieve your bronchospasm by stimulating the receptor that relax bronchial smooth muscle. So earlier we have learned that beta 1 is for your heart, beta 2 is for your lung. So they'll mainly it will stimulate beta 2 receptors and that will relax your bronchial smooth muscle. The side effect, main side effect is dry mouth, paradoxical bronchospasm, nervousness and tremor. Long-acting beta-2 agonist agents are salmeterol, so that increase risk of asthma-related death. Why? Because when patient is having acute attack, so that time we need rescue drug. So that is SABA. So SABA earlier we have seen that we have to use albuterol. Here it is salmeterol, so we cannot use as a rescue drug because it will work late and patient die, and xanthine derivative that cause cardiac arrhythmia and non-cardiac problem like nervousness, tremor and confusion. As a physiotherapist, we have to take care for the asthmatic patient because if they are having asthmatic attacks, so tell them to carry short-acting beta-2 agonist agents as a rescue medicine, and if toxicity is noted, so immediately notify to their physician. Here earlier we have seen that, let's see, short-acting beta-2 agonists are servant salmeterol or albuterol, so that only we can use as a SABA drug, rescue drug. Now we are going to see mucolytic agents, that is pulmozyme means Dornaz alpha and mucosil or mucomist, that is known as acetylcysteine. Mostly these drugs are used for common cold, pneumonia, chronic bronchitis, emphysema and cystic fibrosis. Main mechanism of action is to decrease viscosity of respiratory secretion. Side effect like nausea, vomiting, inflammation of oral mucosa and rhinorrhea. Severe adverse effects are very rare. So as a physiotherapist, what is the consideration for us? If patient is taken mucolytic agents in chronic bronchitis or cystic fibrosis and we are giving chest PT for that patient, so we need to administer chest PT within 30 minutes to 1 hour because this gives our better effect for airway clearance technique. Teach proper use of nebulizer for this patient. If they are not taking proper nebulization, their secretion won't get loosen easily and it will remain thick as it is. Lastly, we are going to see expectorant. So expectorant are guafencin. So guafencin, mostly this is used for common cold, pneumonia, emphysema, cystic fibrosis and bronchitis. Mechanism of action: facilitate the production and ejection of mucus. Side effect like GI disturbance if taken with an empty stomach. So just tell patient, their physician will tell patient to take this drug with some food. So as a physiotherapist, there won't be any specific consideration, but if they have administered this expectorant, so till that time within 30 minutes to 1 hour we have to give chest physical therapy.